It's been really long since we've had a session, and I would like to introduce to everyone Dr. Sami, who is an excellent educator, and hopefully today he'll share some of his insights. Being a senior ED registrar and having worked in the Australian healthcare system for so many years, feel free to share whatever's on your mind, Sami. And for all the participants, I would request you to keep your questions on the side, like just write down your questions. And towards the end, when we're about to finish, feel free to ask your questions at that time. So I'll just give it to Sami and allow him to take over. Thanks.
Hi, good morning, everybody. Can you hear me? Good morning. So my name is Sami. As I said, I'm one of the senior registrars, and I've been working in the Australian health system probably for about 12 years. As you, I came as an IMG. I landed in Australia in May 2008. Did my first I have to do my English test and do the MCQs. Then I did the AMC, MCQ, then clinical. I cleared them probably in 2009 or early 2010. It didn't take me a while after that. I think started working in June, something like that, in 2010. As expected, any IMG, you will probably get the least favorable job. So I started actually in psych for a few months. I actually struggled in the first few years. I struggled a lot, and then I moved a lot until I settled down. I reached this level. So I actually worked in 4 states. I worked in Victoria, New South Wales, Queensland, and South Australia, across 4 states. And you probably worked in probably more than 15, 20 hospitals. So I moved a lot. That's why it gave me a lot of exposure to the Australian healthcare system and give me a lot of experience to reach that level. I joined ED training because I came here initially to join ED training in 2011. And I've been now probably 9 years in the ED training. I managed to clear all the exams in the emergency training, and I left up with the last exam, which is probably similar to it's an OSCE exam, which is similar to your AMC clinical, but it's probably at a much more higher level. That's why I probably share the same kind of struggle with you regarding the clinical exam. I understand that a lot of you have failed a lot in the exam. They've been struggling, maybe financially, emotionally, and a lot of people have told them that they don't worth it or they shouldn't be working in the healthcare system here. But I would like to share something for you to inspire you, which actually inspired me to continue my journey with ED. The slide I will show you, actually the last slide in my presentation. I probably can have say this is what inspired me actually is my hero or my role model in life is Mr. Muhammad Ali Clay. Probably who know about fighting and boxing a bit. Muhammad Ali was one of the best or one of the greatest boxers been ever known in history. A few days ago, I usually in the morning, I listen to motivational talks about, fighting and struggling in life. And a few days ago, I actually come across a quote from Mike Tyson. So Mike Tyson is if you look at boxing history, he's actually one of the greatest boxers. But Muhammad Ali is greater than him because of what brings Muhammad Ali is his personality, his dedications, and his commitment for his career. So what Mike Tyson is said about Muhammad Ali is that Muhammad Ali is the greatest because he is actually he's willing to die. And Mike Tyson, he said, I can't do that. It's impossible, I can't do that. And Muhammad Ali is when he's fighting, he's willing to die. Muhammad Ali will not give up. And I think this is some sort, this is sort of, approach you should approach AMC or you're struggling in life, is that you have to be willing to give everything for your dream or your goal. I'm not necessarily to be death, but you have to start with that mentality. I can tell you is that, the journey is difficult. AMC clinical is the first step in the journey. And the exam you're going to face in the future or the struggle you're going to face will be much more will be probably 100 times or 1,000 times the struggle you're going to face with AMC clinical. Not to scare you, but just to tell you is that you've got a long journey to go. And when you feel down or you feel a bit sad, just remember what Muhammad Ali was doing. In the time, in the time was very difficult that Black people have been undermined and discriminated against. It's still continuing today, but what Muhammad Ali achieved from that was, I think, inspiring for us, all of us. I would like actually to share for you the video. It's very emotional. I actually felt quite emotional to actually listen to the video, to listen to Muhammad Clay talking about, Mike Tyson talking about Muhammad Ali. Let me try so I can share it actually.
Any volunteers? What's happening? Everyone's so shy. How about Dr. Dina Hussain? Would you like to give it a go? Oh, Faika? Faika is really good.
Come on, Faika, don't get scared.
You got this, come on.
I haven't done role playing for a while.
It's okay. You remember Muhammad Ali? Never shared, never scared of any fight.
All right, I will give it a go.
Yep,
Just
good in
don't
you.
laugh.
No, we're all
nobody's loving.
Yeah, we're in it together.
Like, it's okay. I've been probably worse than you when I was at that times.
No, I think you were fine.
All right, you want to start, Faika?
Just give me a second.
That's right, take your times.
Thank you. All right. Hello, Jennifer. This is Dr. Faika. I'm one of the attending doctor today. How are you?
Not too bad. How are you going?
Not too bad. So what brought you here?
Look, I had this. I was shopping in the Woolies and I just collapsed.
Oh, I'm really sorry to hear that. I would like to ask you a few more questions, but before that, I would like to talk to my examiner. Will that be all right?
Yep. Yeah, it should be okay.
Examiner, I would like to know whether my patient is hemodynamically stable or not to proceed.
Yeah, it's hemodynamically stable and can go ahead with your task.
Thank you. So Jennifer, can you please tell me a bit more about it? Like, what were you doing before collapsed?
I was doing nothing. I was just shopping. I was just about to. I was just walking in the grocery into in the food section and was picking up some fruit.
All right. And did you take your morning breakfast?
Yes, yeah, I did.
All right. So when you collapsed, have anyone noticed you?
I think that I feel that the people in the grocery have noticed that, or the supermarket.
Okay. And did you lose your consciousness?
I think so. That's what they told me.
And do you remember like for how long, or anybody told you for how long?
They said probably for a minute or something.
Okay. And did they mention about anything like shaking your limbs or body part?
I think they said you just collapsed and you were stiff or something like that, or you know.
Okay.
Nothing really mentioned.
Okay. Have you lost your control over bowel or bladder?
Oh, I don't think so.
Or have anyone mentioned about uprolling of the eyes or salivation?
I don't think anybody mentioned about. I don't think anybody noticed that.
Okay. So when you got back to your consciousness, after that, did you feel like lethargic or confused?
After the faint?
After you woke up, like got your
Yeah.
consciousness,
did
you feel lethargic or did you feel confused?
I don't think so. I was all right, I think.
Okay. And so apart from that, like, how's your general health?
It's all right. I'm a bit healthy and I think I'm a little bit fit.
Okay. And have you been ever diagnosed with high blood pressure or high blood sugar level?
Oh, I don't think so.
Okay. Are you on any medication?
Just the pills, the contraceptive pill.
Sorry?
The
Pardon?
contraceptive pills, the pills. The
Sorry.
contraceptive pills. The contraceptive pills.
Okay, all right. And so do you smoke?
No.
Do you drink alcohol?
Oh, occasionally, sometimes on the weekend.
Okay. And do you have any allergies?
No.
Okay. Any past family history of heart problems?
I think my grandma probably died. I think she had a heart attack when she was 85 or something. I don't know. I can't remember.
Okay. And so like you have mentioned that you were walking. So while you were walking, like were you um, were sweating a lot?
When I'm walking, I think it
Yeah.
was all right. But I
Um,
think it was, I think it sweat a little bit when I was before I collapsed, probably.
okay. And is this the first time that has happened to you?
I think it happened to me before. I think a few weeks ago, I was cooking in the kitchen,
Mm-hmm.
and I think the same thing happened to me. I didn't bother
Oh,
myself about it.
okay. All right. Okay. Thank you, Jennifer. I'd like to talk to my examiner. Then I will come back to you again. Okay.
Yep, should be okay.
So examiner, I would like to know the general appearance of my patient. Is my patient alert and active?
The patient is sitting on the bed. He's comfortable and
Oh,
look well.
all right. I would like to know the vitals of my patient, blood pressure with postural drop.
Yeah, so blood pressure is 120/75, heart rate is 70 irregular, respiratory is 14s, and oxygen saturation is 100% in warm air. And yep, that's a vital.
Was there any postural drop?
No significant posture drops.
Okay. Then I would like to know the BMI of my patient.
So what did you say?
BMI of my patient.
It's around 25 normal.
Okay. Was there any pallor?
No, there's no problem.
Any cyanosis?
No.
Any edema or lymphadenopathy?
No.
Okay. So I'd like to check the central nervous system, like upper limb and lower limb neurological examination, tone power reflex and sensation, and all the cranial nerves.
So power and sensation and reflexes are normal in both upper and lower limbs. Cranial nerve examination is unremarkable.
Okay, I would like to check the respiratory system, air entry equal and bilateral.
Air entry is equal bilateral.
Any added sound?
No added sound.
On the cardiovascular system, can I see any raised JVP or any
JVP is normal.
calcity? Okay. And so S1, S2 heard any added sound or murmur?
No added sound, no murmur.
Okay. All right. And I would like to do order office tests, urine dipstick, and blood sugar level, and any ECG available.
And not required for the task. So list your differential diagnosis.
Okay, so I don't know what's the differential diagnosis. So, so Jennifer, based on your history, you had a fall, and there could be many reasons behind this fall. Like it could be, uh, like postural drop, like your blood pressure when you are sitting, and when you suddenly rise from the sitting position, then your blood pressure can drop and you can fall as well. It could be like hypoglycemia, like low blood sugar level, or it could be any seizure, or it could be any because of any medication like polypharmacy, or it could be any brain cause, like it could be any stroke, but it could be any vasovagal syncope as well. Like it can happen when there is like exertion or heat. It can um, excite your vagal nerve, that can lead to fall. So at this moment, I'm not sure what's going on, but I would like to evaluate more by
Can
doing
I go
some.
home then? I'm just in a hurry. I've got the kids to pick up from school.
So at this moment, without the evaluation and without the, so I would like to involve my registrar here. So I can't take the decision that whether I can let you go home or not. So I can arrange some social service to take care, take responsibility of the kids at this moment while you are at this hospital. So
Do
will
you
that
think
be all
that,
right?
doctor, do you think that the cause is serious? Like, am I gonna die from it?
At this moment, it is very difficult to say anything like that. So we need to do evaluation, like what's going on with you.
No.
So we need to find it out first.
Thank you for
Without,
time is done. 8 minutes. Thank you for your thanks for your
thank you, doctor.
feedback.
I know I messed up, but like,
No, you did a great job. It's actually very impressive job. You did very well. But I probably give you a couple of advice so you can actually
yeah,
maybe help you in the future. Is that remember the in the AMC exam or any examinations, what make somebody who's a local graduate performing better than you is that and able to communicate a more complex medical concept in a very simple language. And you will be surprised that they actually focus a lot on that. So avoiding medical jargons as seizure or faint or syncope, they will actually stress a lot on that, especially when you communicate with the patients.
yeah,
Secondly is that I'll tell you one advice actually helped me a lot even when I was preparing for the exam. For any topics, it's very difficult for me to find the language or the way how you explain it in a lay person language. So what I
yeah.
advise you to do is that there's something called Better Health Channel,
Mhm.
something like that. Have anybody heard about it? It's called Better Health Channel, which is basically gives
Yeah,
you patient informations.
yeah,
If you go under the title of syncope, or for example, vertigo or chest pain, anything like that, it will actually use, I will explain to you the language or the way you
yeah,
should explain it to a patient. And how do you explain to him the reasons or the investigations or the disposition which is going to be discharged or go home, what
mhm,
investigation what sort of sign and symptom he watch out for. It's actually very useful to read it and use the same terminology they use there in your language. So try to I know it's a bit difficult for us because we don't use the language. Try to avoid
yeah,
any medical jargon because they will take it as a penalty for you if you use
yeah,
medical jargon, especially when you talk with the patients.
yeah,
Secondly, is that this is the way I would try my best to to help you with through this session is to actually help you to structure yourself.
yeah,
What they if local graduate when they go to medical schools, they will teach them structures, and the structure make them look more precise, more focused, and they look confident when they actually have structures. So it's very
yeah,
important to understand, to have some sort of structures when you approach history physical examinations or you
mhm,
approach differential diagnosis. And the last thing I will tell you is that don't get fussy if you've been thrown with the difficult questions. The best thing you can do is that stop, don't say anything, take a pause, and think about what you're going to say. And make
yeah,
sure that what you say make quite sense for you. Especially if when someone said, the patient say, well, can I go home? Okay, take a pause and think about it. What are you going to say?
yeah,
You can, for example, say, look, I would like you to go home, but I'm a bit concerned is that we haven't found the cause for your faint.
okay,
Um, I need to run some couple of tests and also need to get some advice. You can say, well, instead of saying I'm going to talk with your registrar, just use a different language. Say, look, I'm gonna seek advice from my colleague or my supervisors because
mhm,
I'm not exactly sure. I'm a bit also concerned. So if you use a similar language, that will make you more superior
yeah,
and look more clear. And what's important for them is that you look safe. What they're
yeah,
looking for in the exam, they're looking for somebody who confident, have a safe approach. So he's not going to make a silly decision. He's just going to make a safe decisions, which is he's not sure. He will go and ask for advice, and he'll be honest with the patients. Then let's move on and let's talk about syncope. To be honest with you, syncope is extremely difficult. Actually, it's a very difficult topic. It's not an easy thing, and even a senior registrar or other registrar will actually struggle to go through the history and physical examination to find the cause. This case supposed to be, from what he described for you, is this is a simple vasovagal attack. which is a benign cause, and the patient can go home probably without any investigation, apart from you can do a BSL, or you may even do you can even do an ECG if you would like to. So let's talk about syncope. So what's the definition of syncope? Anybody can share? You just try to make it an interactive session. So syncope is transient loss or transient loss of consciousness due to localized or systematic hypoperfusion to the CNS with a quick regain of conscious level after resuming, being into supine positions. What's my role? What's your role in emergency or somewhere in a GB practice when you deal with somebody with syncope? Your main role is to differentiate between benign causes and life-threatening causes. And that's what we do, risk stratify patients based on history, physical examinations, investigation include bedside, we call them bedside, and invasive investigation or invasive investigations. So you will get your answer you get the majority of your clues and answer when you take about history and physical examinations. That's why I would like it to be very well structured when you approach history of syncope. To develop a structures, you need to actually understand what potential causes for somebody who actually, patient when you come to the to hospital or they come to the case, they wouldn't say for you, I had a syncope. Syncope is a medical term. I would say, I have fainted, I felt lightheaded, and I felt dizzy. And some people will say, I don't know, I just collapsed. And you'll find it in the exam. They will say that I collapsed, fainted, felt lightheaded, and felt weak, maybe, for example. The first step is to differentiate between three main categories, okay? So category number one is Brie Syncope, which is we describe as transient loss of or reduction into the CNS perfusions. Secondly is that it could be possibly to be a vertigo. Vertigo is a different expressions. Vertigo is sensation of imbalance, which is sensation of your position in space, or sensation of motion or imbalance, which is some people, especially elderly, they can mix the two different things. A third thing is that you can include is collapse, like seizures, or other causes like psychogenic and other things. The trick for you to find the difference between three things is to ask not to ask the patient the description what happened to him, because they will confuse. Is to ask him is that what was the circumstances at the time when the event happened? So circumstances around the event, which you did very well, Faika. You asked it about what happened, what she was doing when this event happened. Tell you a bit of a couple of examples is that somebody's been sitting on a bed, standing up, for example, a 70-year-old lady, lying in the bed, wake up in the morning and stand up from the bed, and she was walking to the toilet, early in the morning. After a couple of steps, she felt lightheaded and collapsed. Then the last thing she can remember is that her husband tapped in her shoulder, and she felt sick with it. She felt vomited, maybe, for example, and within minutes start to wake up and she's back to normal. So that's description fit with what? Anybody can tell me what does it fit with?
Postural hypotension.
Exactly right. So this is fit with the postural hypotensions. Second thing is that if you imagine different scenarios, somebody is sitting in a chair, an old lady, she's 85, sitting in a chair with her families and having dinner, sitting in a chair having a dinner. And suddenly the people notice that she slumped in the chair. Okay. Then they lower her to the ground and they notice she is pale, maybe a bit sweaty, unresponsive, and they call the ambulance. And when the ambulance arrived, we'll probably, when the ambulance, by the time the ambulance arrived, she's already back to normal. Anybody guess what's the cause of that? Anybody? Faika, maybe? What do you think of that?
Get out of mute and talk, guys.
Come on, don't be shy. It's all right. There's no wrong or right answer. We're here to guide you through that.
Vasovagal?
Okay, vasovagal. Why do you think it's a vasovagal? Manju, is it? Yep.
Yes, yeah. because she was like sweaty and she regained consciousness within a few minutes. If it is
But what do you
the,
think?
But
What do you
she
think of the
failed.
position? She was sitting in a chair.
Yeah, she was
Did she
yes.
change her position? No, she didn't change her
Mhm.
position. Does that make it more likely to be a vasovagal? Possible, yeah. But is it more likely to be something else? Do you reckon?
Is it maybe hypoglycemia?
I didn't hear you.
Is it maybe hypoglycemia? Hypoglycemia?
Possible, but we can check the hypoglycemia. You can check the blood sugar. Probably the ambulance will check it there at that time. But is there anything more serious than that?
I think
Yes.
something related to
EIA?
cardiovascular system because she was pale.
Correct. And what else? You're right. So being sitting in a position, so didn't change her position, indicate for us is that hypotension or postural hypotension was eliminated from the story. The fact is that she's 85, and more likely people who is 85 have ischemic heart disease and multiple comorbidities. And she actually collapsed, slumped into the chair, and she was lowered when she was looking pale. Making me more concerned of something suddenly happened is not related to positions, which is make it more likely to be arrhythmia. I'll be very concerned about the arrhythmia here.
Yeah.
See, I mean, asking about the circumstances around the event will help you a lot. So what you're looking for, the prodromes before it happened and what happened after the faint. An example of that, somebody who have a sudden onset of headache, then collapse. What do you reckon the cause will be?
SH? Any bleed in the,
Right,
any
absolutely right.
intracranial bleed?
So intracerebral hemorrhage, stroke, subarachnoid hemorrhage, what does it cause to the brain? It actually increases the intracerebral pressure suddenly. When you increase the intracerebral pressures, that will reduce the cerebral perfusion, because cerebral perfusion is MAP, which is the blood pressures, minus the intracerebral pressures. If the MAP is maintained, because there's nothing changing the MAP, and you have sudden raise into the intracerebral pressure, what happens is that you've got a reduction into cerebral perfusion and cause a collapse. Very common when people come with a subarachnoid hemorrhage, they come with a headache, secondly, they collapse, make it very likely for a bleed or intracerebral events, including stroke or bleed. Other things that Vaka, you did actually very right. You asked the patient about whether she have any medical illness before or she has been well in the last few days. An example that I can tell you about causes like Abargia bleed. They will come with, for example, they will come with a melena for the last few days. Some people will become sick. Maybe they will be coughing, having fever, having abdominal pain. And that will indicate for you something like sepsis, hypovolemia. Example of the people who has been having diarrhea, an old lady has been diarrhea for 3 days and vomiting, then she was standing up and she fainted, and make it more hypovolemia as a more likely causes. Also, you consider also abdominal pain. When you have abdominal pain, you have collapse. What do you think is the cause for that? Something more dangerous. Anybody?
Aneurysm.
Ectopic pregnancy?
Ectopic pregnancy.
Aortic dissection?
Yeah, ectopic pregnancy, you're right. When you are a bit younger and
Aneurysm?
exactly right. Abdominal aneurysm can actually present with a sudden abdominal pain and also collapse. Okay, so what actually tell you what actually guide you through the cause is asking about the prodrome, the duration of the syncope. If the patient regain consciousness and become back to normal within a few minutes, it's more likely to be benign cause. Prolonged syncope or prolonged loss of consciousness to the time when she arrived at the hospital. That's important when you look at the EC, look at the ambulance. They say, look, whether they reported any hypotensions at that times or reported any arrhythmia at that times, or the patient had been arriving in hypotension, make it more likely to be a dangerous cause. Chest pain also before the attack is very important to consider. That will guide it through cardiac cause, including STEMI, example of cardiac tamponade, thoracic aortic aneurysm dissections, for example. That also guided through the other cause. So as I said, you need to ask all the circumstances around the event before, during the event, anybody witnessed the event, how long is the unconscious been going for, what did the patient look like, as I said, as we said, did the patient actually has been seizing maybe, for example, or looked pale, for example, or vomited maybe blood, or opened his bowel and, you know, had a melena, and for how long he's been unconscious for, and what did he felt after he wake up? If he wake up and he's still having chest pain, having headache, having a neurological deficit, for example, or did he have any weakness, numbness, as FICA described? Did he have any weakness, numbness? Do you have a slurred speech? Do you have difficulty finding the word? Anything indicate for you a stroke or a bleed? So after moving from the history of the circumstances that have been around, you go and ask about risk factors for dangerous cause. And FICA did the right thing, is asking about, does the patient had ischemic heart disease? Is he in medications causing arrhythmia? Is been having any sign of upper or lower GI bleed? Has been having diarrhea? Is the patient have a previous episode like that? Then you ask about family. Family history is very important, but you need specifically, if I can mention exactly what you're looking in a family history. And instead of saying, look, you have a family history of ischemic heart disease, you can tweak a little bit the language a little bit and make you look more smarter and help you to look more shine. And when you present to the examiner, you look more knowledgeable and more confident. That you can say, for example, is that you have a family history of sudden cardiac death in younger people, for example, age less than 40. You have history of bleed in the brain or brain problems in younger people, for example. And you have a family history of, I probably it's very difficult to ask the patient about aortic aneurysm, but if you show the examiner that you exactly asking a specific question in the history, this actually will help you to look a bit more shiner. So that's talking about the history. So some station will actually ask you about some sort of investigation, or basically let's talk about examination then. And moving from history to the physical examination. Like I did the right thing, you ask initially about what's the appearance of the patient. Does he look sweaty, pale, jaundiced, cachectic, for example, have large abdominal pain, is he in distress, for example. Then you ask the first thing you ask about vital signs, including sign of shock, hypotension, tachycardia. You check the pulse and was it regular or not. After moving from the vital signs, you need to be systematic when you are actually asking about the examination. Say to the examiner, I want to examine your neurological system, starting from cranial nerve, any abnormality in your cranial nerve. That will indicate for you a neurological cause, any lateralizing sign or deficit, which including weakness, numbness, or absent reflexes, or change in reflexes in both sides. Moving in from the CNS examination, you go to the, as like I said, going to the cardiovascular examinations. And you start by auscultation of the heart. What you're looking for, and just make it brief. You're looking for change in the apex speeds or apex positions, which indicate for congestive heart failure, any added sounds or murmurs to the heart, which indicate for you structural heart disease, puts patient at risk of syncope, including aortic stenosis, for example. Then you look for evidence of congestive heart. You look for evidence of heart failure, which is raised GVB, lower limb edema. That will help you to risk stratify patient with ischemic heart disease and congestive heart failure as risk factor for syncope. Moving on, you go to the respiratory system. It's mainly three systems actually cause that, which is CNS, cardiovascular, and respiratory. And it's mainly respiratory. You're looking for something like tension pneumothorax causing obstructive shock. So you look for centralized trachea, the presence of air entry on both sides, and equal entry on both sides, any added sounds. That is briefly enough to get you through the respiratory systems. Then look for abdominal examination, looking for any palpable aorta, any abdominal tenderness or sign of localized peritonism indicating, for example, ectopic pregnancy, aortic dissections, or sepsis. And then you also look for rash indicating anaphylactic reaction, for example, as a cause of distributive shock. That briefly get you through all the all the physical examination related to syncope. I think briefly that should be enough for you to go through to roll out the most serious cause as we've been describing. As the most important thing is that to be very systematic when your history and physical examinations. Moving on from history and physical examination, some station will include investigation. What investigation you want to order? Anybody want to give me a clue about what investigation you want to order? Anybody want to share? Sarisha or Sirsha?
There's no right or
We
wrong.
can use ECG.
ECG, excellent choice. The first test I'm going to do is ECG. What are you looking in ECG for? Just briefly.
ECG to rule out arrhythmias or prolonged QT.
Correct, exactly right. And so I will give you one advice. Instead of saying arrhythmia, you can actually make it much more smarter, look much more smarter when you say, I'm looking.
Atrial fibrillation?
Exactly right. So what you're going to say in ECG, I'm looking for sign of brady or tachyarrhythmia. So tachyarrhythmia like SVT, VT, AF, and bradyarrhythmia like heart blocks, sinus bradycardia, or something like that. And also you can say, I mentioned that I'm looking for a sign of ischemic heart disease or acute coronary artery syndrome or STEMI, for example. Or you can say congenital abnormality. Sorry, congenital abnormality will include, as you described, as prolonged or short QT. So moving on from the ECG, ECG is actually, if it is going to come in the exam, it's going to be pass and fail criteria. ECG is extremely important in syncope. Secondly, moving from ECG, what's the next step? What is the next test you're going to do?
Full baseline sugar levels.
Basal is very important. Yep.
And
you rule out hypoglycemia.
Serum electrolytes.
Okay, good. Why you want to do serum electrolyte? What are you going to look in electrolyte for?
I mean, even the electrolyte disturbance may contribute to the arrhythmias.
Correct, you're right. Which one specifically?
Potassium.
Excellent. So you need to mention that. When you mention that, you will actually look much more smarter and much more brighter when you actually present yourself. So look and say, look, I'm going to do UNE, looking for acute electrolyte disturbance, including potassium hypo or hyperkalemia. So that's very important. Also, you can add and say, look, I'm looking for a raised urea and creatinine, which indicate for me dehydration or sign of upper GI bleeding. So you have a high urea compared to creatinine. Moving from UNE, what's the other test you're going to do?
If it is a young female, we can do the urine pregnancy test.
Excellent. So within the childbearing age, all of them should, at least they should get a beta HCG. What else are you going to do?
And if it is, if they are having any stroke features, then we can do the CT.
Oh, so excellent. So I say if the patient has sign of CNS cause, I will do a CT scan CT scan, plain CT scan plus minus perfusion scan. So nowadays, the people who come with actually stroke symptoms, if you work in hospital, you will see we have a stroke code, which include a plain CT scan, perfusion scan, or angio plus perfusion scans to rule out, stroke and to assess whether they are or candidate of thrombolysis or reperfusion therapy. So you can say that. What else are you going to do?
And if the patient is having any seizure episodes, then EEG.
Yep, EEG, yep, fair enough. You can admit them into EEG or do it as a patient. What else?
And if a patient is pale and anemic, we can go for full blood examination.
Exactly right. So what you're looking in FBE is that you're looking for sign of anemia. Anemia as a cause, as a chronic or acute through the upper GI bleed, for example. What else are you going to do?
And if the patient is, we are suspecting abdominal aortic aneurysm, then ultrasound abdomen.
Ultrasound, we call it a bedside ultrasound as a rule out or a quick rule in. And you can also do a CT AAA images.
Okay. And if the patient is, we are suspecting any cardiac cause, we need to do the echo, 2D echo, cardiogram.
But there's another blood test you can do quicker than echo.
Tropi and cardiac enzymes.
Yeah, cardiac enzyme including troponin. Okay, that's probably should be enough for you to rule out the most serious causes of syncope. So let us go through the summary. So syncope is extremely difficult cases and a bit challenging. That's why you need to be a little bit more structured in your approach especially through history taken, physical examination, and investigation, which is might look you, smarter and brighter, and will help you to pass the exam. And be clear in your language when you speak, and be very specific, and use lay-term language when you speak to a patient. So the most important thing is that to differentiate between life-threatening and non-life-threatening, and to differentiate between syncope as fainting or syncope and other causes, including vertigo, which is going to talk about in the next case. As I said, the most important thing is that to ask about circumstances around the event, prodrome, which is before the event, during the events, including witness, how long the prodrome for, or how long the symptoms been for, and what's the symptom after the prodromes when he wake up, what sort of symptom he have, how long it's been there, is it persistent at the time when he actually came to the hospital. And also you need to ask about the triggering factor at that, or circumstance triggering factor at that time. Was he standing up? Was he lying in bed? Or what exactly was what he was doing? Is he been receiving a bad news and he fainted, which is making it more likely to be psychogenic vasovagal attack? Or the patient was sitting in a chair and suddenly collapsed without any chest pain, which make it more likely to be arrhythmia, especially in older populations. And you have to go through, in your history, you also have to ask about associated symptoms, and you go through them systematically. Which make you look much more better or smarter. Ask about CNS symptoms, including headache, weakness, deficit. Ask about chest pain, short of breath, which indicate for the cardiovascular or respiratory cause, including BE. Also ask about previous few days, whether there is any illness, including gastrointestinal symptoms like diarrhea and vomiting, any sign of upper or lower GI bleeding, including vomiting blood, coffee ground blood, or sign of melena or red blood passing through the rectums. Also ask about other associated symptoms, including, as I said, headache, and going through them systematically. As I said, CNS, cardiovascular, respiratory, GI, which including the bleeding and the dehydrations, and also ask about, don't forget also ask about medication history, including specifically medication which is predisposed the patient to arrhythmia, including any anti-arrhythmic medication like cetalol, beta blockers, amiodarons. All these medication will put the patient at risk of having arrhythmia. Ask about medication which is predisposed patient to syncope or Brie Syncope, including alpha blocker, for example, like prazosin, for example, which is predisposed the patient for postural hypotensions. Ask about family history. Specifically ask about history of sudden cardiac death before the age of 40, any stroke or a bleed in the brain before the younger age, less than 40, and any other risk factors. Then, as I said, move on into the investigation, including starting with the ECG, PSL, pregnancy test, which is a bedside. Then you go on and ask about FBE, so looking for anemia, electrolyte, and UNE looking for life-threatening electrolyte disturbance, including hypo and hyperkalemia, or sign of urea, indicating upper GI bleeding or dehydrations. Also, you ask about troponin. You can do some imaging, which including brain images, CTBA if you suspect PE, and you can also DD dimer, and you do CT abdomen if you are worried about aortic aneurysm. So that briefly should run. I mean, if you go through all that, you should score 100% in that case. I don't think anything you're going to be able to miss with that. And you make sure that you read actually the way how you explain it to the patients, and you listen to the patient, answer their questions. Any question regarding this case? Feel free to ask any questions.
Hi, can you please tell about the vasovagal syncope scenario? How does that present? Okay,
very good questions. I like this question. You know what? If you go, there's a score actually, risk stratification score recorded Canadian syncope rules. The Canadian syncope rules actually is a guiding tool to help you to differentiate between life-threatening and non-life-threatening, which is non-life-threatening including a syncope, including postural hypotension or vasovagal attack. People who have a vasovagal attack usually will be younger people, doesn't have any risk factor of ischemic heart disease or arrhythmia, either through their history or family history. And the prodrome happen when they are actually either changing positions or being receiving an emotional triggers, or they've been actually standing. So there should be an actual change in positions from standing to sitting positions, or being standing in an upright position with no associated other symptom, which is rule out the other risky condition, including chest pain and short of breath and other symptoms. And the episode usually lasted for a minute or two with a quick recovery. And there is no symptom after that. So if you roll all these things, it should be enough for you to say, this is more likely to be a vasovagal attack. As this patient, which is the 40-year-old Jennifer, who is in a shopping mall and is standing quickly, felt lightheaded and sweaty and collapsed, and within a minute she's back to normal, she's standing up. Doesn't have any risk factors from either from history or family history or medications, which is make it more likely to be a vasovagal. In this case, you probably wouldn't need much apart from BSL and ECG, maybe if you are already persisting. And you can discharge this patient safely. Any other further questions?
I have added the score, the Canadian Syncope risk score in the chat. So feel free to have a look at the link. It talks about the points, what the criteria is. Go through it whenever you have time. And it sounds more logical when you can even ask your examiner, what is the score? What is the Canadian Syncope score? Or this is what I would do.
Yeah. As I said, the Canadian score is actually risk stratification score. It contains history, physical examination of hypertensions. It includes two tests, which is ECG and troponin. And I think it might include family history or something like that. So it's basically going through the risk factors.
I have a question. What is the more empathetic way to ask about the any death in the family of young people?
You can just briefly say, look, do you have any history that one of your close family members, so you have to say close family member, have sudden cardiac death due to heart condition or a brain condition? So briefly say that.
Right, thank you.
Yeah. Any other questions? The best information or best picked resources you can read actually is, I think it was James Hayes' notes. And also if you go to the update is more extensive. But if you go to any emergency textbook like the textbook, or even if you go to Mortag textbook, or you even go if you Cameron, which is the emergency textbook, and you open the chapter about vertigo, or sorry, syncope, it will actually get you through the details of what he's been describing here. And if you follow any YouTubes, for example, Life Translations has a bit of information. IMRAB, for example, is very useful resources. There's a lot of online resources you can actually go through, and will get you through the same information I've described for you. Everybody happy? You move to the next case. Okay, so I'll give you 2 minutes. Can you everybody see it? So I'll give you 2 minutes or a few minutes to read this case, and I will be the candidate or the confident, sometimes they call it, and you can take history from me.
Do we have any volunteers who'd like to give it a go?
It's okay, don't be shy. It's time to practice.
Dr. Jenny, would you like to try?
Okay.
Yeah.
I'll just try,
okay.
but not having too much preparation.
What was that?
Actually, I'm not too much prepared for that. but I can try.
Okay, great. Yeah, it's all about trying.
Always about trying. You know, don't be scared, don't be shy.
Okay. Give it a scenario.
Okay, so what you need to do is that I think, have a look at the case, try to think about this, try to structure yourself about history and what examination you asked for, and how you're going to present yourself to the examiner for the last 2 minutes. Okay? I'll give you 2 to 3 minutes to think about it then. Okay?
Okay.
I'm just going to go.
It's okay. I cannot say the scenario still.
Can you see the case on the screen?
Okay.
Yeah. So the case.
Yes.
Yeah, your next patient is a 33-year-old male by the name of Thomas Dixon, who presented to the ED where you work as HMO with dizziness and vomiting since 2 days. He works as an auto mechanic and has been unable to go to work, feeling unsteady on his feet. Your task is to obtain a focused history for 4 minutes, ask for examination findings from examiner, specifying what you're looking for, and explain the most likely diagnosis and investigations to the examiner. So just think about it, like what comes to your mind when you look at dizziness and vomiting. So structure your history in that way. So think about it, take your time.
Okay. Okay, you may have that timer. I'm ready.
Okay, let's wait for Sami to come back. He's the role player and the examiner.
Okay.
Okay, have we get somebody to be a volunteer?
Yeah.
Yes.
Yeah. Okay. Give me a second. I'm just going to start the clock in a second.
Okay.
Okay. You want to start? Go ahead.
Yes. So, good morning.
Good morning.
Good morning, Doctor. I'm Dr. Jenny, honestly attending physician here. So, Thomas, I got to know from the notes that you're having some kind of strange feeling like dizziness and vomiting. So, I want to ask you some questions about that. But before that, I have to ask your stability from my examiner. Is that okay with you?
So the patient has a normal vital sign and look well. You can proceed with your task, please.
Okay, so if my patient is vital stable, to go for further history.
Just come closer to the phone. I can't really hear you. I think there is a bit of noise there.
Okay, thank you. So, coming back to you, Thomas. So, are you now comfortable enough to answer few of my questions, please?
I couldn't hear you. What did you say?
So, are you now comfortable enough to answer few of my questions, please?
It's very hard for me to hear.
Yeah, your voice is breaking, Jenny.
Okay, my in this side my internet is a little bit slower, so that I can, so that you can't hear me properly.
Yeah. We might get somebody else if he had a better microphone. I think it's very hard for us to hear.
I can volunteer.
Yeah, go for it. Yep. Sorry, I'm just going to restart it again for you.
All right.
Yep.
Hi, it's Dr. Naila here. I'm one of the ED doctors working in this hospital. Thomas, can you tell me more about your condition?
I don't have a condition, but I just came here because I'm been feeling dizzy. I'm not exactly sure what's happening.
Right. Are you feeling dizzy even now?
No, I think it did stop. It did stop a while ago.
All
But it's
right.
been going for 2 days.
All right. So just give me a moment. I need to ask your vitals from the examiner. Mr. Examiner, is my patient vitally stable?
Yes, patient is stable, vitals are stable, and he's well, and you can go ahead with your task.
All right, thank you. Okay, Thomas, please tell me, when did it started?
It started 2 days ago, actually.
All right. And can you describe your dizziness for me? Does it include any fall or any funny turn?
Look, I feel a bit dizzy. Like, I don't know how to describe it. I feel like sitting in a rocking boat or something like that. Like, the floor, the ground is just moving or swinging side to side.
All right. And any pain around your body?
No, I'm not really. No, I'm not sore anywhere. No, just this dizziness and vomiting.
All right. And any other abdominal symptoms like diarrhea?
No, I don't have any diarrhea at all.
All right. And or any headache or fever?
No, I don't have any headache or fever.
All right. And any loss of power or movements around your body or altered sensations?
I don't think so.
All right. And this is the first time you experienced this?
Well, I think I had it a few years ago.
All
Same
right.
thing happened to me, but I just, lasted for a day or two, then disappeared. I didn't bother myself about
All
it.
right. And did you had a proper follow for that condition back then and was diagnosed
Too
with
busy,
something?
too busy with job, with work.
All right. And are you on any kind of medications right now?
No, I'm very healthy and fit.
All right. And do you have any family history of any medical conditions?
Like what?
Like any heart problems or any vessel problems?
I think I think my father, he probably had a heart attack when he was 85 or something like that. I'm not really sure.
All right. And any history of increased cholesterol levels?
Oh, I haven't been checked for that. I couldn't be bothered.
All right. And can you please tell me that do you smoke or drink alcohol or do recreational drugs?
Look, I smoke sometimes,
All right.
occasionally sometimes, and once a year, maybe if we have a party, we might just smoke some marijuana. But yeah, and you have a couple of beers sometimes after work. Nothing really.
All right. And is it possible that you came across with any kind of poison lately?
Like what?
Like as you work at an auto mechanic shop, so have you got any exposure to polyethylene propyl glycol or any petroleum product or
Look, I think we deal. We've got a lot of oil and stuff, but look, I don't think I have taken anything of them. Like, I'm just be careful with that. Like, I don't think so.
All right, that's great. It's just that I want to think about different conditions in your case. All right, and okay, thank you, Thompson, for your history. Now I would like to get back to Mr. Examiner and ask to know more about your condition. All right?
Fair enough. Yep.
Okay, Mr. Examiner, I would like to know about the vitals. Are they changed from the previous ones that you told me?
His blood pressure is 121/65. Heart rate is around 66 and normal sinus rhythm. His oxygen saturation is 98 and warm air. Respiratory rate is 14 and no work of breathing.
All right. And is ECG available?
We finish with the physical examination first.
All right. And I would like to know about the general appearance of my patient. Is he looking pale?
The patient is sitting on the bed, comfortables, and yeah.
And the hydration status?
Well hydrated.
All right, thank you. And now I would like to go for the examination of the hands to know about the nails, color and any changes in the skin, hydration,
No
and
colors, and there's no
pulse?
obvious abnormalities in the hand examinations.
Right. And on oral examination, is there any positive finding?
What positive finding are you looking for?
Any signs of cyanosis or dehydration?
No sign of dehydration or cyanosis, central cyanosis.
Or any infection?
No sign of infection in the mouth.
And ear examination, is there any positive finding?
What is it?
Ear examination?
Ear examinations? You mean ear examination? Ear examine normal?
All right. And on chest examination?
Yep.
Any increased work of breathing, any abnormal sound or edit sound?
Respiratory examination, good air entry, bilateral, and no added sound.
And on cardiac examination, cerebrovascular examination, any positive finding?
Anything specifically in cardiovascular examination you're looking for?
Yes, the epic speed, is it in the right place or where it is located? And any a murmur I can hear?
Epic speed is with the normal positions and no added sound to the cardiovascular exam and to the.
All right, yeah, added sound. Yeah, thank you. And on it, abdominal examination, is there any positive finding?
What positive finding you're looking for?
Any pain, tenderness, any obvious bulge?
No, the abdomen is soft and relaxed, and there's no evidence of organomegaly or palpable mass.
And on neurological examination, is there any I would like to go with the eye examination first, and then reflexes, change in sensory and motor reflexes.
No, look normal.
All right. Thank you, Mr. Examiner. Are there any office tests available, like ECG or blood sugar levels?
Not part of the task. Can you list your differential diagnosis, please?
All right. It looks like the patient might be having any raised intracerebral pressure. So I would like to investigate him for that. And
any further differential diagnosis you would like to add to the list?
Yes, food poisoning, electrolyte imbalance, prolonged or short QT interval, any arrhythmias, tachyarrhythmias or bradyarrhythmias, and poisoning from pyrrolium chemicals, more specifically polyethylene propyl glycol.
Yep.
And aneurysm.
Excellent. So task is finished, complete, time is complete, and thanks for your help. Good job.
Thank you. Thank you.
Look, excellent job. You've done very good, very well. I'm just going to add a couple of things for you, just probably to add it on so you can actually improve your performance a little bit.
Sure, thank you.
Look, again, most of us will, I mean, if you'd say all of us will have the same trouble with the same problems. And we need just to focus on these things, which is, as I said, watching the language, specifically avoiding medical jargon. And as I said, it's very important. You can improve that either by reading the leaflet, or actually watching that. One of the things that we can do, watch patient education videos, actually, and what's the language exactly what they say. How do they describe things? How they actually describe the term. For example, fever. Instead of saying fever, you can actually say, did you have any temperature? Because fever is a medical term. Don't use any, try not your best not to use any medical jargon and use the alternative terms they used in the local language. And you can get it basically from YouTube's or educational channels or something like that, or leaflet. You'll see what specifically for the language they watch. If you watch somebody else, like a local graduate, when they talk with the patient, you can actually guess it from them. You see, watch them how they talk and how they describe things. Second is that the other thing which actually lack most of us is the brain mentality or the structures. It's actually, to be honest with you, I was probably worse than you when I was starting. it took me a while and so many years of studying and exams, doing exams, to actually learn how to actually develop structures. I think it has to do with also with our cultural language thing. These, local grade, they learn from the basic schools, from the primary school, they learn how to approach things through structures. And medical school actually teach, the most important thing they teach them doesn't have to be the knowledge, is actually how to approach things in a structural way. This is the thing which you actually need to develop from early stage in your learning through AMC. When you approach history physical examination, be precise and have a structures. Jumping around within history from past medical history to history of illnesses, current illnesses, from cardiovascular symptoms to neurological symptoms, between them, make you not look clear or not confident. And that's why you need to go through them systematically. I will try my best to get you through the causes of vertigo systematically, so you can actually go through them. And finally, you just need to practice more. So let us talk about vertigo in general then. So what's vertigo? As you described it before, vertigo is sensation of imbalance. If you look at the medical term, they use a sensation of balance. Have anybody experienced dizziness before? Like, have anybody had actually vertigo or dizziness before? Anybody? I'm sure a lot of you actually, very common symptoms. I had it myself. I just had, I usually have it a lot. Even when I was talking with you, suddenly sometime when I changed my head, I just had a little bit of spin. Anybody just, want to describe actually what does he feel? It's slightly different from syncope. Some people, they use the same term, dizziness. They might actually alternate because different people use different languages or different terms. But syncope or faint or lightheaded is feeling that you're gonna faint or you're gonna what the other description is that the blacking out. I never experienced blackout before, but I can't really remember. I can't really actually describe it, but I have dizziness before. So people describe it as, as being through a tunnel or a dark tunnels, or feeling sweaty or feeling a bit kind of pale and sweaty, and they just black out, they lost consciousness, or they lower themselves to the ground. Dizziness is slightly different. Dizziness is, you feel the surrounding or the floor or the ground is actually trying to move, specifically related to the position change and head position change to the space. Very commonly is this described, and this guy who described for you is that he actually feels dizzy when he actually turns his head in position to his body. So that makes it more likely to be vertigo. If he described himself standing up or sitting up and suddenly felt a tunnel vision or something like that, more likely to be a Brie Syncope. And to be honest with you, sometimes elderly people, half of the times, they can't tell you the difference between is it syncope or vertigo. There's another trick which actually help you to differentiate between them, is that association with times and association with circumstances or association with the event. Example of that is that vertigo usually associated with changing in head positions. And in relation to the time will help you to differentiate between both of them. So vertigo is turning, feeling of balance when you're actually turning your head to the side or one side, or getting, when you're in bed and you're turning your head, or you're working in, this probably, for example, this guy is a mechanic and he was working with his tools and he suddenly turned his head and he suddenly felt dizzy or felt that the room is spinning or something spinning. And he actually had nausea and vomiting with it, which is more likely to be vertigo. Okay. The second thing is that you ask about, the most important, you ask about triggering factor or associated factor, or triggering factor specifically. What triggered the event? Is the event have no triggers? For example, he was sitting in a chair and suddenly felt fainted and collapsed, or he actually related to the head position change. As I described before, he was using his tool, turn his head or something like that. So association with turning of the head in space make it more likely to be vertigo. Then your next step is actually, first step is to differentiate between vertigo and syncope. and we described it as before. The second step to differentiate between life-threatening condition causing vertigo and non-life-threatening conditions. Anybody know what's the life-threatening conditions of vertigo can be? So basically, let's start. Where is the sense of position in our body? Where does it come from?
Cerebellum.
Cerebellum is one of the part of the trach, but where does the trach start?
Stroke in the cerebellum.
Yes, of course, stroke is the one of the central cause, but is the trach or the
from the ear?
Yeah.
Yes.
Yeah.
Start from the semicircular canal, the 3-1. Start from there, from the middle ear, go through the 8 cranial nerves, go to the midbrain, and from midbrain go to the cerebellum and go to other part of the brain and come back again through the same pathway. So differentiate between central and peripheral cause. Usually peripheral causes are benign causes, not life-threatening, which include benign positional, paroxysmal positional vertigo, Meniere's disease, upper respiratory tract infections. Probably a lot of you have probably one day had otitis media and felt a bit dizzy with it. That's a peripheral cause. Central cause, as you described before, there's many causes include MS, including a tumor to the midbrain. But what we are concerned about, what we are focusing here in emergency, especially this patient came to the emergency, we're talking about stroke, specifically posterior circulation stroke. So the posterior circulations supply the base of the brain, including the midbrain, and also supply the cerebellum, which is the area, which is the nucleus for the 8 cranial nerve go, and also the nucleus from the 8 cranial nerve goes to the cerebellum to make organization of balance. So our role is to differentiate between peripheral and central. And the way to differentiate between them is through the features, through the feature of the description of the vertigo, and also through risk factor associated with it, and also through some special, we call them, examinations, and also special tests, which we're going to talk about in the next few minutes. So let us talk about what symptoms or what circumstances associated with, describe a peripheral vertigo versus a central cause. So in general, a benign cause or peripheral cause of vertigo has this very specific feature of the vertigo. Patient will describe the vertigo as triggered by head movement, where there is what we call it a latency. Latency means that there is a time around 20 to 30 seconds, or probably 10 to 20 seconds between the head movement and the starting of the vertigo. So he turned his head, not immediately feel dizzy. Now, after a few seconds, he started to become dizzy. Secondly, is that it fixation. We call it fixation. Is that if the patient looking in one direction, he doesn't change his head, the vertigo or the symptom disappear. Okay, in comparison with constant going vertigo all the times, not related to head position, which is making it more likely to be central. Third is moving on to the description of the vertigo associated with nausea and vomiting. Actually, the more severe the nausea and vomiting make it more likely to be a peripheral vertigo. Anybody have seen somebody with benign positional vertigo before, or benign positional paroxysmal vertigo? Anybody have seen one before?
Yes.
Yeah, have you seen one before?
Yes.
How do they look like when you see them in hospital?
I mean, they complain of dizziness when they change their position during sleep.
Yeah, and how they look in general? They look awful. They will look gray in color, actually, because it's actually a very awful feeling to have. You wouldn't like it when you have it. It's a very awful feeling. The nausea is severe to the level is that the patient can't tolerate the nausea. Mm-hmm. And that's why they come immediately to the hospital, rather than the central cause, which is actually the patient can't tolerate the symptoms. It will be lasting. Usually the patient will be having the symptom for a while, for hours and hours and hours, before actually he can notice that and come to the hospital. Secondly, is that that's based on history. It's basically what we said is that it's position, so position related to the position. It's fixations. It can stop by fixations. There's latency period, and it is actually unidirectional. What's unidirectional? Because it's affected usually, it's very unusual to have two semicircular canal affected at the same time. it usually happens in one direction. So the vertigo we describe for you by looking in one direction, either right or left. If you're having a vertigo or sensation of a dizziness, both direction, make it more likely to be central in cause. Okay. As I said, it's more likely to be paroxysmal, so it actually lasts for a few minutes, then self-resolve. And actually, it's fatigability, what you call fatigability. What does it mean? Fatigability is actually improved by times. The more time you move your head, it will become less and less and less until disappear. Very unusual for a peripheral cause to be lasting for days. Usually for a few hours, then self-resolve, then come back again after a few hours or a few days. That's a characteristic of peripheral, including benign positional, paroxysmal positional vertigo. Moving from there, you look at associated symptoms. Again, peripheral vertigo is localized to the ear. You're more likely to have ear symptoms, which including sign of upper respiratory tract infections like sore ear, runny nose, cough in the last few days, and feeling actually deafness. Deafness actually indicate more likely to be a peripheral cause. When you have fluid in the middle ear, you're more likely to have a middle ear pathology. And also tinnitus is actually a feature of either middle ear pathology or Meniere's disease, which is both of them are peripheral cause. What associated with central cause is other neurological deficits. Very important to ask about other neurological deficit, either through cranial nerve examinations or through lateralizing symptom, which is the weakness and numbness in both or in any directions. Central cause is either related to the midbrain cerebellum. So remember, 8 cranial nerve has very small nuclei in the midbrain. Very unusual that you have a tumor or you have a stroke involving just one cranial nerve. The space is probably, you're talking about 1 to 2 millimeters. Very unusual to have a clot just affecting one cranial nerve. Usually have multiple cranial nerve being affected. That's why people who have diplopia, numbness of the face or any change in the smile or gag reflex or anything like that, more likely to be some sort of pathology somewhere in the midbrain. People have cerebellar sign. What cerebellar sign are you going to look for in history and physical examinations? Anybody can help?
Gait is important.
What did you say, sorry?
Gait?
Exactly right. Gait is very important. So cerebellar sign is gait, ataxia, or truncal, we call them truncal ataxia. And when you ask the examiner, you ask him about truncal ataxia. What does mean? Truncal ataxia mean is that it's actually not a disturbance into the way you walk, because you can actually get you get unsteady gait when you're actually having a peripheral vertigo. But with what's specific about central cause, they have truncal ataxia. If you've seen somebody who had a central stroke, when they're sitting on the bed, they're not sitting straight. They're sitting in a position. So they're sitting either on the right or the left. That's what you call it truncal ataxia. When they walk on a gait. So they walk in one direction. So that's what we call it truncal ataxia. Secondly is that what's the other sign of cerebellar sign you look for? Coordinations.
Finger nose test.
Finger nose test or dystidiokinesia. Yeah, alternating hand movement. Sometimes you can have dysarthria, change in speech, or dysarthria, or some visual disturbance even, because that's also part of the posterior circulation stroke. You can involve the posterior, the posterior fossa there. Yeah. Then moving from history about that, you move on to the we're moving on to the physical examinations. And what's important in physical examination, most of these central cause are actually brain pathology. That's why you need to focus on specifically, very brief, you need to ask about cranial nerve examinations, and posterior cerebellar signs, and any lateralizing signs, including weakness, numbness on any directions. Why? Because when you actually involve the midbrain, you're more likely to involve the descending tract, which is involve power and sensations, or it can involve reflexes even. That's why you ask about 3 things. You don't actually need to examine the cardiovascular respiratory symptoms when you actually have a clear description of vertigo. But you need to focus into ear examination or ENT examinations. Why? Because it will direct it through benign causes, which include paroxysmal, otitis media or any ear pathology. And there is, I'm not sure whether it's probably part of your, of your curriculum or not. You can actually look up for vesicles in the ear, inside around the ears, which is directed through what you call Ramsay-Hunt syndrome, which is herpes zoster involving the 8th cranial nerve, which can manifest by vesicles around the external auditory canal, which is they consider as a serious cause. But I think it's probably beyond the scope of AMC examinations. But ENT examinations seem able to rule out a peripheral cause, including perforated eardrum or something like that. I don't think you need to do any other test apart from that. And also the next step that you move on is what we call it specific test or special test. Anybody know about what special test?
Halbite.
Halbite, yeah, Halbite maneuver.
Okay, yeah, Dick's Halbite maneuver. What's the benefit of Halbite maneuver?
The stigmas is to be seen.
Exactly right. So if you don't have any stigmas at that time, Dick's Halbite maneuver will actually help you to elicit the stigmas and help you to differentiate, to describe the stigmas. And Halbite maneuver is actually part of another test, which we call it hint test. Anybody know what hint tests mean? Any answers? Hint test is extremely important. It's probably going to be part of pass and failure in the stations. Head impulse is one specific test which is helping to differentiate between central and peripheral cause. If you read any textbook or any articles or anything about peripheral and central cause, we'll talk about hint test. And there will be a lot of video tubes you can watch if you want to just type hints, which is HINTS test. If you just Google it, it will come with a video and will explain to you how do you do it. Hint test consists of 3 parts, which is head impulse, nystagmus, test of skewer. I'll try briefly to describe for you, but I recommend that you go and watch it on YouTube and read more about it. Head impulse is basically, if you watch the tube, is basically holding the head in a straight position and turn it to the side 10 to 15 degrees and bring it back to the center or bent line positions. Patients who have a positive test, which is basically correction of the eye. So when you hold the eye will move with the head. When you bring it back again, you will see overshooting or corrections. Positive test is actually benign, meaning you're dealing with a peripheral cause. If there's negative, where there's no corrections, it's actually serious. It indicates a central cause, more serious cause. Then you examine, when you elicit a Halbite test, you need to describe the nystagmus. To differentiate between peripheral and central nystagmus is as we described it before. Peripheral nystagmus is it's unidirectional, so it's usually one direction, and there is a latency, which is, as you described, it is 10 to 20 seconds of latency between the head movement and the starting of the nystagmus. In comparison, constant vertigo immediately happen is indicate more central cause. Directions. Vertical usually benign because with a vertical nystagmus you get posterior semicircular canal, which is the commonest cause of benign positional paroxysmal benign positional vertigo. Compared to vertical nystagmus, which indicate more likely to indicate a central cause, more dangerous cause. And also there is what we call it fatigability, which is when you repeat the test multiple times, Halbite test, the vertigo will settle down, the nystagmus will settle down, and will settle down by times, and also fixations. So the benign position vertigo, when you trigger it, it will last not more than a minute or 2, then it will stop. In comparison with the central cause, which is last for minutes or maybe hours even, and has no triggers, it will happen by itself without any movement, and it will be both direction. It might be vertical even. And when you examine the ear, you will find some abnormalities that indicate a peripheral cause. Then the last one is the test of skewer. I will let you go and watch the tube about it. It's basically, it's alternating covering of both eye, and we alternate both eyes, covering both eye. When you remove the cover, you will see there's a corrections of the eye, correction of the eye movement up and down, which is indicate a more serious cause. Okay, so I'll let you later on read about it and watch the video. It will explain to you more in details, and we can ask questions maybe at a later stage about it. So what you need in examination and summary, what you need to focus on is basically CNS examinations and ENT examination. That's it. You don't need anything else. And the CNS examination you need to focus into cranial nerve examinations, because cranial nerve involvement means a central cause. Secondly is that you need to look for cerebellar sign, which is truncal ataxia, coordinations, and schizokinesia. Also, you need to look for lateralizing sign, which is a weakness or numbness or sensing sensations in one side compared to the other side. And then eventually you do the hint test, which we describe later on. Is there any other investigation you do? If you are clear from history and physical examination and that this is a peripheral cause, you don't need actually to do any other test. It should be enough. It should be enough with that. People has a central cause, you require an imaging on them, which include a CT brain, may include admission and doing an MRI at later stage 4 to look for posterior circulation, posterior fossa pathology, including a stroke or tumors, which might be a bit tricky to see in a CT scan. That's why you require admission and MRI at later stage. Just going back to the history, talking about the circumstances associated with the vertigo you also need to risk stratify patient based on their previous history. An example of that, 85-year-old lady who has AF or been blood thinners or been diagnosed previously with, for example, breast cancer or bowel cancer, more likely, just by chance, more likely to have a central cause rather than this guy who is 33 years old, healthy and fit, doesn't take medications, been having a paroxysmal dizziness for the last 3 days. So just by asking about history, you can actually tell. When you ask about family history, as I described before, you need to ask specifically what you are asking for. Any history of a stroke or a tumor or brain pathology in younger age populations. That will take you about family history. So that's briefly to get you through the history. That gives you through the definition of the vertigo, the likely causes of the difference between central and peripheral cause, and how to differentiate between them and associate it in relation to time versus vertigo, with it constant or paroxysmal, and also the description of the vertigo, the triggering factors for it, and the relieving factors, and risk factor associated with central cause, as we described it before, risk factor like old age, being medication, have history of tumors, family history of a bleed or intracranial pathology before in younger age populations. Then we move on to doing a general physical examination, including cranial nerve examination and posterior cerebellar sign and lateralizing sign, and added on is the ENT examination, looking for peripheral cause as ear pathology or ENT pathology. And so to briefly get you through the history of physical examination and the stations. I'm sure I've talked a lot about it, but anybody have questions? Is that clear?
Yes, sir. First of all, thank you for your feedback. Then I have a question that, as you told us about the Canadian risk assessment score, can this Hall-Pike test or HINTS test, they can be asked from the examiner during physical examination findings?
Yeah, so I think when you ask the examiner about the examinations, you probably can start asking about what's the vital signs. I'm not sure whether it's going to add much or not, but you can actually ask him about, I want to do a CNS examination. You can say to them, I want to ask about CNS examination, including starting with cranial nerve examinations from 1 to 12 cranial nerve. Secondly, I want to do cerebellar signs, including gait. Romberg text, for example, you can do that. And coordination and schizokinesia. And peripheral examination, looking for lateralizing sign, including examination for power, sensation, and reflexes. And briefly, then you move on and say it's normal, for example, then you move, I want to do a special test. You call them a special test. I want to do Held bike test, Dick's Held bike test to trigger the vertigo, trigger the nystagmus, so I can describe the nystagmus. Then I want to do hit impulse and test of skewer. That should be enough to give you a full mark when you say that. Even if I think if you are a consultant, even level, emergency consultant, that should be enough for you to pass, to score the best score.
Okay, got it. Thank you.
Yep. Any other further questions? Don't be shy. I know you have limited questions. Go ahead and ask. Anybody have questions? What do you think of the case? This is actually, doing vertigo is actually extremely difficult. If you get a vertigo case, the majority of people actually fail the station. Even to be honest with you, even a registrar will probably junior will fail the station even. Anybody have questions? So vertigo, I recommend that you read James Hayes' notes. Watch the YouTube about hand test. I think if you go to life, anybody know what's life in fast lane?
Yes.
Yeah. So life has very good resources. Up to date may be a little bit useful, but a little bit more details. And you'll find some explanation either in Cameron's textbook of emergency. Everybody know it? Anybody know it? Yeah. So get Cameron. Also, Murtag has a good chapter. I don't think your role, even in this case, to give the right diagnosis, I don't think your role is to say this is probably benign position of vertigo or this is a Meniere disease. I don't think that's going to be pass or fail criteria. What's important for you to say is that, is this a benign or this is a dangerous cause? Can I send this patient home with some Stemetel or something like that? Or I need to admit him further investigations. Murtag will tell you about explanation about feature of penile position, like labyrinthitis, labyrinthitis or otitis media, or Meniere's disease, different description of peripheral causes. What's important for you in this task is to focus is then what's the difference between central and peripheral cause, which is very important for them.
Should we check for neck movements to rule out cervical spondylosis?
So what did you say?
Should we ask for neck movements to rule out cervical spondylosis?
Very important questions. Yeah, you could. Yeah, you could do that. And also, I forget to mention one thing is that part of the one of the central cause of vertigo is that you look for what we call it vertebral artery dissections, which usually come with neck pain in aggressive movement. It's very typical history is that people who go to a chiropractor, they manipulate their neck and they come with dizziness. And that's probably can be related to sudden movement of the neck or manipulation of the neck, which is caused because the vertebral artery actually go through the spinous canal, and you can actually dissect them when you're doing that. So asking about pain, any neck pain, is very important, which is differentiate between neck pain and ear pain. That's why ear examination is very important when you have pain, when you have ear pain, because if you have local pathology in the ear, it makes it most likely to be ear rather than something like vertebral artery dissections.
Thank you. And should we ask about a caloric stimulation test or any Fukuda stepping gait test?
I don't think, look, to be honest, I don't think you need to read about them because they're very special tests. Maybe the fancy neurologists will spend their days doing them. We don't know how to do them. And there's no times, other things out beyond the scope of our practice to do them.
Thank you.
As I said, cranial nerve examination, peripheral neurological examinations, and hand test should be enough for you to do it. If you need further tests, probably you need to admit them and get an MRI done. And then neurologists can scratch their head doing, caloric test or something else.
Thank you.
Yeah. Any other questions? So if nobody, no other questions, I would like to thank you for, participating in this session. I'm really sorry that I didn't prepare any much slide because I'm not very good into IT technology. I was trying to find some technology when I actually can handwrite or some sort of handwriting while actually presenting, talking with them, or something like I can share my handwritten note or something like that, because I'm more into handwriting stuff rather than actually typing into a laptop, because I'm just an old style fashions. But hopefully in the next few sessions or maybe next few weeks, I can sort out some technology which actually help me to type or write when I'm talking with you guys.
You did great, doctor. Thank you so much for your time. We really appreciate that.
Sami, there's a question from Dr. Al-Sadi. He wants to know, how was your experience in the Australian healthcare system and with the clinical exam?
Look, to be honest with you, I mean, the AMC clinical will be the first hurdle you're going to face too, and the hurdle will grow and grow by times. Coming to a new country is very difficult. You're gonna have to deal not only with the knowledge and the skills, also you need to deal with the culture here, including work cultures, patient culture, patient expectations, and understanding the language and the communication. It will take time. It's just basically time and hard work. And remember what Mike Tyson said about Muhammad Ali: do not get defeated. And once you've been beaten up or you've been knocked down, just stand up and keep fighting. I can tell you that I've been through a lot in my training and my careers, but the more hurdle you go through, you become stronger, you become smarter, and you become more confident. It'll just take time. I mean, I've probably reached this level after you've been battling with the healthcare system for probably over 10 years now. I've been through a lot. I did emergency, I did critical care, I did even pre-hospital, I did retrieval, I did search and rescue, I did overseas missions, didn't work in 4 states. It's just hard work, basically. Yes, you will be a disadvantage. Yes, I would say to you, you will be disadvantaged, but what actually makes you stand from the crowd is hard working, dedication to your career and your career, basically, and your education and training.
Great. Yeah, that's it. And someone's asking, what's the difference? What's better to start in a GP or RMO?
I think you should start anywhere you can actually find a job. You need to get into the system first. When I started, I actually did psych. I started in a psych ward, which is a lot of you will probably end up in doing some either psych. You're either going to doing the less favorable job, either doing a psych, doing ED, or doing GP. I don't think it will be very hard and tricky to find surgical rotations or gynae or pediatric unless you have a little bit more experience in that field. Just go and find any jobs. Just start from anywhere. And move on. Once you get into the system, the healthcare system, you will progress. Once you find a job, you start working. You get recommendations. They know that you work. You know how to work. You just find your way. It just takes time.
Yeah, that's it. It's all about perseverance. Keep trying, and keep moving on. Yeah, that's about it.
Even if you fail the exam once or twice, 3 times, keep going. Stand up and keep fighting. Keep fighting, as Muhammad Ali was doing. Keep fighting. You're not going to knock me out or knock me out from it. I'll just stand up and keep fighting, and that's what make Muhammad Ali great, is that he just keep fighting and he's willing to die for it. He's not going to give up.
Yeah, that's it. You have to keep trying. And Sirisha is asking, how are the chances with AMC Part 1? Sirisha, do you mean with the jobs?
Yes.
Yeah, so there are people who've got jobs with AMC Part 1, but of course you have a higher chance of getting a job if you pass the clinical. It's important and you cannot bypass it. You have to do the clinical at some stage.
Yeah. And as I said, if you can't access some supervision, some of observership in hospital, just watch your YouTube. Watch your YouTube. How they, I think the best thing to do is that watch other people, how they do the OSCE. Look for a local graduate or some graduate in UK, for example, graduate in America or Canada. watch them how they perform, and copy them. There's a lot of courses. I think there's multiple courses, even lab courses, or for example, or USMLE clinical thing, or some OSCE for medical students. There's a lot of courses for them. You can actually join them and actually learn from them.
Yeah. Awesome, that's great. Sami, I'll request you to make me the host again. And thank you so much for your time, Sami. Really appreciate it.
Right.
And all the participants who joined today, thanks a lot, guys. Keep on practicing, keep on going. It's all about perseverance, keep trying. It's a journey, and it's more about enjoying the journey than reaching to the destination. So I would recommend enjoy the process, have fun, keep on going. You've had a long break of not studying, and I hope now, you know, things can start, and, you know, AMC's restarted the exams. So please get back into the study mode and get going. Yeah.
How can you make your host?
In the participants, click on more, and like over me, like
enable
as the participant. Yeah, enable host. Great. And can I please request the participants, if you could give a review on what you thought about the session today, if you enjoyed it, if there was something that you wanted differently, or something that you did not like, whatever it is, like your honest opinion. And if there are other topics that you need help with, feel free to message. So yeah, feel free to message on the Pass AMC group on what you really thought about the session today, if you thought it was valuable, and what if you would like other sessions like this in future, and what topics would they be. Yeah. And thank you so much for joining.
Make your host now.
Awesome. That's it. Yeah. Thanks, Sami.
It's all right. Pleasure to help.